Thank you to the organizers for the opportunity to address this audience today and for the chance to bring pediatric HIV back on this important stage. When I was asked to give this presentation, I was obviously honored and very excited about the opportunity to share my perspective with you. And I asked myself, what would my audience know about pediatric HIV? And you are probably all well aware that the global HIV community have made tremendous progress over the last 10 years in preventing vertical transmission and reducing the number of new pediatric infections. We've heard that the large majority of pregnant women that know their status are offered antiretrovirals, and that a number of countries have achieved or are on their way to reach elimination of vertical transmission. Now, you may wonder, what's left to address about pediatric HIV? And isn't it just a matter of time until we get to a time when there's no children living with HIV and we have an AIDS-free generation? Well, let me ask you a question. Why is it okay that only today 400 children acquired HIV infections and 260 died because of AIDS-related condition, reflecting the disproportionate mortality that affects children compared to adults? Why are we finding that 40% of HIV-exposed infants do not receive a virological test in their first 2 months of life, when we know that disease is fast and time is little? Why do we accept that only half of the 1.8 million children living with HIV receives life-saving antiretroviral therapy? And even if they do so, only 1 in 3 achieves virological suppression. And I'm afraid to tell you, this is not going to get better. Why? Well, because we are in the middle of a public health earthquake called COVID-19 pandemic, which is exposing our weaknesses and potentially reverting a lot of the progress we've made so far. We're hearing of mothers and children not able to reach the facilities because of the public health measures, or because they don't find transport to get to the facility, or because they're scared and don't know enough about COVID-19 transmission. As a result, we're hearing of women not attending antenatal care and mothers and children not being tested or provided with ART. We've also documented important stockouts of pediatric formulation at a time where finally countries were making a big move to more optimal regimens. Now, we don't know what the impact of COVID-19 will be on our journey to achieve an AIDS-free generation, but colleagues like John Stover have tried to use modeling to address this question. And he used the AIM model to explore a number of scenarios. So let's have a look at it together. You can see they explored a number of scenarios with different degree and duration of disruption. And from this work, we can expect 86% increase in the number of new infections in children, taking us back to where we were in 2014. We also know that the consequences of these disruptions will go beyond COVID-19. And you can see this in the second graph, where AIDS-related deaths are plotted over time. Well, this additional mortality is going to continue, and we have to get ready to prevent it and deal with it. So I guess you can see that this is really not a matter of time. This is a matter of action. And I really think that we can't sit here for 10 years waiting for an AIDS-free generation to come. We need to focus on our program and strengthen them, do the things that we know that work and do them better, because we have no time to lose. As we do so, we might need additional evidence to inform the way we combine interventions and how we take them to scale. As such, we'll need operational research that will inform the way we deliver services in the future. And as we do so, we will also need to push the innovation agenda forward to ensure the new tools are available to diagnose and treat better children living with HIV. These are my 3 key messages for you today, and I'm going to expand on them one by one. So first, act now by returning to the basics and introducing the new tools that we now have available. Because we know what works, we need to do more of it and do it better, because we have no time to lose. And when I mention returning to the basics, I refer to things like testing the kids who are sick, or looking for the children in their family where they acquire infection, through index case testing and family-based testing, This data is presented at this conference by Hilary Wolf and team, and they looked at the level of uptake of index case testing in a number of different countries with PEPFAR-supported programs. They also report the yield of this strategy in different age groups, which gives us a measure of the number of children identified over those tested. The key message of this paper is that implementation of index case testing is still very limited in most settings. But when you actually do it, you can identify a considerable number of children, particularly the young ones, that would otherwise go undiagnosed. We know that this intervention is cheap and we know how to deliver it. So there should be no excuse for not testing children of the parents that live with HIV and are right in front of you. When I talked about the new tools that we now need to use, I certainly referred to point of care for EID. We now have multiple randomized controlled trials that demonstrate that if you use point of care for EID, you can reduce the turnaround time of the results down to a few hours, and in that way, shorten remarkably the time to treatment initiation. This was true in several countries with strong and weak lab systems, and this policy has been uptaken, but use is still limited. So what are we waiting for? Now, what we learned through these studies and the implementation work that has occurred so far is that for these tools to be fully transformative, we need to combine them in packages and not deliver them in isolation. And this is certainly true for infants who, unfortunately, are still presenting very high mortality, as reported from Zambia at CROI this year. Some of these children are on a very rapid trajectory of disease progression, and the window of opportunity to save them is very tight. We know that in the past, we've struggled significantly with providing the right treatment to them, either because we were given the medication they were resistant to, like nevirapine, or because we were given medication that were not in child-friendly formulations, like lopinavir/ritonavir. So it's very clear to me that we need to strengthen and improve the package of care for infants. And I think that perhaps today we are a step closer to that. Why? Well, because after many years of work to identify a regimen that could be fully harmonized across age groups, durable and tolerable to address HIV drug resistance, we might be finally there. In June 12, dolutegravir was approved for all children above 3 kilos and 4 weeks of age. And 2 generic formulations are on their way and awaiting regulatory approval. You can see here pictures of fully dispersible formulations that have a good taste. And all of this was possible thanks to an unprecedented level of collaboration that happened between the innovators, research networks, donors, key stakeholders, and generic manufacturers. So I want to call on this as an example of how we should be doing things in the future. There's other reason to be optimistic about pediatric HIV treatment, as there are a number of new developments. The 4-in-1 fixed-dose combination was developed and awaiting regulatory approval, potentially by the end of the year. We know that this formulation will be a critical addition to the toolbox that we have available to treat children, particularly for those that do not tolerate dolutegravir. Despite delays and some of the side effects that we're seeing in adults, TAF remains an important option for children, particularly in light of some of the NRTI resistance that we see on the rise in countries. Development of the darunavir fixed-dose combination is about to start. And we know that this formulation will be important because it will provide us a potent PI option for use in third line and perhaps in the future in second line. Now, this is not it. There is a number of antiretrovirals that are in the pipeline and that are at advanced stages of development and investigation in adults. These new ARVs are in the hands of very experienced innovators that I want to call on today to step up and show us how we can do things differently and take this medication much faster than ever before to children. Earlier, I talked about the things that we don't do enough of because they're difficult to do. And certainly addressing advanced HIV disease is one of them. But when we still have 30% of children and adolescents presenting with severe immunosuppression, we must take this seriously. And we know that we need to equip that frontline workers with the tools and the capacity to be able to screen, treat, optimize, and prevent tuberculosis, as well as other infectious diseases that are too often causes of deaths in children. There's also interventions that we don't implement because perhaps we haven't understood how important they are. And this is what I call the fourth 90. Because we shouldn't only ensure that children and adolescents survive and reach virological suppression. We should ensure that their quality of life is improved and that they reach their full potential. But we can only do that if we equip our healthcare workers to be able to screen delays in neurodevelopment and in growth, if we promote nurturing care for children that are living with HIV and children that are exposed to HIV, if we focus on nutrition and are able to identify those disabilities that require referral and appropriate care. And finally, but very importantly, the psychosocial support and the appropriate care for mental health issues that are becoming so important in adolescents who have lived their entire life with HIV. Until we've tackled the forward 90, we will not be done with this work. I'm now going to move into my second key message to reflect on the fact that in order to achieve impact, often the way we deliver interventions is as important as the intervention themselves. This is a good example coming from Zimbabwe, where the Africa Jandiri group tested a new approach to provide HIV services to adolescents. Through a cluster randomized controlled trial, they demonstrated that if you provide HIV services to adolescents through their peers, you can improve virological suppression and improve their overall outcomes. Now, this is one of the few examples of well-conducted operational research that not just improved policies, but also changed practice. The CATS model that they've investigated is now being adopted and adapted in a number of sub-Saharan African countries. And I think that we should do more of these kind of research and ensure that we identify new solutions and test them in multiple settings. How do we identify new solutions? Well, sometimes when we are under pressure and finding alternative ways of delivering services to patients is a necessity. And this is where I see COVID-19 as an opportunity, perhaps to do those things that we were reluctant to do, like uptaking multi-month dispensing for children and adolescents. As you can see from this map, that is a result of a quick country survey that we've done in collaboration with our partners. There's been wide adoption of multi-month dispensing for children and adolescents at the time of COVID. And we really hope that this work will not be reverted once the epidemic is under control. We've also seen digital tools being used more and more, particularly for adolescents, to provide information and to provide support. The CATS model that I mentioned earlier is being translated into a fully virtual platform to deliver support and follow up adolescents living with HIV. Now, we know that digital tools have limitations and certainly don't reach everyone in need. But this helps me to make the point that COVID-19 can be an opportunity that we should capitalize on. We should use it to generate new ideas and take them into the future and be able to improve the way we deliver services to our patients. But we have to test them because we know that the way we combine intervention needs to be adapted to the epidemic context and the local characteristics. We know that these requires operational research that not just helps us to understand if a new solution has an impact, but also to understand how we can take that solution to scale. Unfortunately, this type of research is often overlooked. It's not well funded nor systematically supported. And I think we should really work on this and ensure that those that are on the ground that can lead this work are equipped and supported and better connected through strong collaborations that really maximize the know-how in this field. We know this is important because what works today might not work in the future. And so it's really critical that we generate the evidence to tell us how to combine intervention for the future and how to locate commodities and capacity to be able to respond to the new epidemic context where having less children and adolescents living with HIV will not make it easier to provide services to them. I'm going to now move into my third and last key message, which helps us to reflect on the fact that if we want to improve the future, we have to start and work on it now. And again, I think that COVID-19 gives us an opportunity to see how we can do things differently. Over the last 6 months, we've witnessed an unprecedented level of collaboration in the R&D space. We've seen high political support resources being generated, competitors coming together to enable new discoveries. We've seen researchers exploring new methodologies to address some of the key questions we had, and we come together to implement adaptive trials that would test multiple therapeutic options at the same time. And for children, we've seen the recovery trial designed as an adult trial, including pediatric subjects from the very beginning, and remdesivir pediatric investigation plan being designed and approved very rapidly as a simple PK study where children of different ages are enrolled at the same time according to weight. Now, this should not be an exception. This should be the standard, particularly for a disease like HIV that right now has a much higher mortality compared to COVID-19 based on what we know. So I really hope that COVID-19 can inspire us and take us closer to, for example, an EID equivalent of a rapid diagnostic test for adults, cheap and easy to do so that HIV testing can be more equitable for everyone. And also, we want better drugs to be available to children more quickly. We need these therapeutics to be investigated much earlier than ever before so that we don't have to wait for 10 years before we actually get these drugs in the hands of children. We know we have several technologies in the pipeline, and these slides summarize some of them that are also included in a landscape that Unitaid led with the collaboration of WHO. You can see technologies for oral administration and non-oral administration. Some of them are already available, but perhaps have not been used enough. Some are around the corner, and others need to be further investigated. Those that are of particular interest are the ones with long-acting potential, because they would be of great value for adolescents that struggle so much with adherence, or with the babies with whom providing drugs is such a battle. We know, however, that these technologies will not get to the hands of children unless we proactively intervene and ensure that they are considered and applied to pediatric medicines. These require partnership, efficient and effective. And this is really the key principle behind the Global Accelerator for Pediatric Formulation, a WHO network that we set up and are implementing in close collaboration with our funding members, CHAI, ECPAF, MPP, and PENTA. Through GAPF, we will ensure that key priority products are taken through their product life cycle, and that research is being optimized, that development happens quickly, and that introduction and rollout is not an afterthought, but plan ahead. Because our work will not be done unless better ARVs are in the hands of children and adolescents living with HIV. So again, these are the three key messages that I'd like you to walk away with. Act, research, and innovate. In my job, I have the privilege to interact with many individuals that really care about children and adolescents living with HIV. There are true champions out there that are leading pediatric and adolescent programs on the ground, and they can be the force behind the change that needs to happen. But they need resources and they need our support. There are also many very experienced researchers that just needs to be inspired and connected so that they can evolve and develop their work. Lastly, we have very experienced innovators that have the capacity and the resources to be able to take new tools into our future so that we can better diagnose and treat HIV in children and adolescents. So I really call on us today to not let COVID-19 stop our progress. COVID-19 can make us bounce forward. We're not done yet, and certainly we can't give up now. We can get to an AIDS-free generation, but we must do it together. Thank you very much for listening and for taking what I said with you. I also want to thank friends and colleagues that have contributed to this presentation, to the various groups that I work with, to family, mentor, friends, and colleagues in the pediatric and adolescent HIV community who continue to inspire the work I do. And lastly, but most importantly, children and their families, for whom I hope I was a voice today. Thank you.